start by thanking all of my colleagues who are here, and I'm going to run very quickly along the line and introduce them. So this is Alex Rampotas. He works at UCL. Next to him is Donal McLaunan, who's the current chair of the MPN study group in the UK. Claire Woodley, who is our advanced nurse practitioner at Guy's. Jen O'Sullivan, you've already met. Alessia Khan, who's from Leeds. Anna Godfrey, who's from Cambridge. Andrew McGregor, who's from Newcastle. Mary Frances McMullen, who's from Belfast. Nauman Butt from Liverpool. John Lambert, you've already met, also from UCL. Jyoti Nangalia, Cambridge. Natalia Curto Garcia from Guy's. Fran, now I have a panic about how to pronounce your surname. Wadelin from Nottingham. Rachel Wells, also from Liverpool. And Joanne Ewing from Birmingham. If there are any clinicians lurking in the audience who also want to come and sit here, you are really welcome. So, we didn't have time to do a Q&A after the last session, so if you had any questions from that, feel free to ask them. Most of the people who were in the last session are still in the room. If not, maybe we'll start with a question from online, Nauman, while people get ready with their questions in the room. Donal, you get to be up first.
Okay, so good to see everyone after lunch. So the question that came in online was it's a very specific question about the correlation between having an MPN and the risk of second cancers, and could that simply be explained by increased surveillance and pick-up rate? And I think when we look at the incidence of second cancers, we need to be clear it's an absolute problem, but the risk is low overall, but it is an absolute risk. And I think the etiology of that, as others this morning have very clearly explained, is probably due to the immune system, when you have an MPN, not being able to surveil the potential risk of a cell changing, as well as someone who is matched to you who doesn't have an MPN. And I think secondly, there's always the risk associated, albeit small, with the treatments that we use, because they can also modify the immune system. And John, earlier today, if we're thinking about skin cancers, showed how some drugs can affect how well a cell can repair itself. And also other drugs like JAK inhibitors, we've seen that all of the commercially available JAK inhibitors have a slightly increased risk of developing a skin cancer, and that most likely is because of their effect on the immune system and how well they can surveil changes within the skin. And I think the study that Alex, John and Jyoti are leading in the UK will help us understand that more.
Great. Any questions in the room? Yeah, a couple here. Lots of questions in the room, that's good.
I wanted to ask what the long-term risks of interferon were, and also how interferon works compared to hydroxycarbamide for ET.
Okie doke. I'm going to ask Jo Ewing, could you mind maybe touching on how do they work differently and long-term risks of interferon, if you're comfortable? First to say, there has been an interferon shortage due to a lot of work from people on this panel. We are the only country in Europe that has access to best remi for all MPN. So that's really good. Also, due to a lot of work from advocacy, from John, working with, and Andy Tattersall as well, working with other blood cancer charities. So your voice being heard in that way is really important. That's given you time to think about how to answer the question.
Yeah, thank you. A great question, and one that's very difficult to answer. So I think for a number of reasons. So I think if we tackle how each of them work differently, we know much more about how hydroxycarbamide works, because it's a standard chemotherapy drug, and so we know how that affects the cells in the bone marrow that are proliferating, that are dividing, and slows those down. Interferon, a much more difficult beast, and I'm not sure we really do understand exactly how it works, but it's what we may call immune modulating. So it's modulating the immune system to be able, potentially, I guess, to mop up the cells that are causing the issue, or to change the environment that they're in, such that the cell numbers are suppressed, and as we've heard, sometimes the VAF or the VAF can come down with interferon. Can also rarely come down with hydroxycarbamide, so there's a bit of a tussle. But how does it work differently? So we do seem to see some remissions with interferon. Tend not to see that with hydroxycarbamide, so there's sort of like different things. Interferon longer term. Interferon doesn't necessarily suit everyone, so it can be difficult to use in patients, for example, who've got a history of depression. It can worsen that situation. It can be something that can trigger, say, thyroid problems or immune problems. So patients with already established immune disease, I'll be quite cautious about starting interferon in those patients. So it doesn't suit everyone. But longer term, if you don't get any of those sort of shorter term problems, then generally I'd say longer term we don't have any evidence that interferon is a problem. We also importantly use interferon because we, whilst it's somewhat off-label, there seems to be no impact when patients want to become pregnant, and so it can be used relatively safely in pregnancy. So that's another sort of situation that's really important. But longer term risks, not a lot in terms of signal for long term risk. I think I would be right in saying, but I'd be happy for any of the panel members to sort of add to that information.
Agree. Good. Another question?
Hello. I'm up here.
Perfect. I see you. Hello.
Hello. I have ET-JAK2. I've also had 2 other different types of cancer over the last few years. I have another mutation which I saw up on the board a couple of times, the TET2 mutation, and nobody has yet been able to explain to me the significance of it, and I'm hoping to find out today.
So, I think that's a great question for Jyoti Nangalia.
Thank you, Claire. So one thing to say is that they're both probably doing different things. So the JAK2 mutation we know is what's driving your ET. What the JAK2 mutation does is there's normal JAK2 in all cells, and when JAK2 becomes mutated, it basically signals to make more platelets or more red cells. So a normal mechanism within the stem cells in your blood is overactive. So we know that the JAK2 mutation is driving your ET. As we get older, all of us, we start to develop mutations within our blood. That can be a JAK2 mutation. Not everyone with a JAK2 mutation gets an MPN. TET2 is one of the commonest mutations that we just develop as we get older. There's another one called a DNMT3A mutation. They're all genes that get mutated as we get older. They don't necessarily cause a problem. The TET2 mutation can be either within your ET or it can just be in your blood, and it's often very difficult to know. Now, within the field, there's a sense that some mutations are high risk and some mutations aren't. The TET2 mutation is not one that is particularly high risk. It's not one that we worry about or that we would change treatment because we saw it. It's hard to know specifically what every combination of mutations will mean for a particular patient, but we do know overall that within a large group of patients, people with some mutations may fare worse than others. And our next step is to try in the future and go, well, what does that mean for therapy? We're not quite there yet. We're still at the process of working out what mutations matter and what mutations don't. So in your case, I suspect it wouldn't make much difference, and we'd still be treating the ET as per the normal national guidelines. But
Perfect.
anyone else, please add.
No, agree. Another question in the room?
Hello, I'm at the back. I just wonder what the panel's view on low B12 and MPNs is, because I've heard a lot of people say there's no correlation, but I can probably guess that at least 50% of the people in here are taking B12 supplements. So is there a correlation? And if so, why, if you've got an MPN, do you have a low B12?
Right. I'm going to ask Fran to answer that question. So, that's actually quite tricky, but we did used to use B12 levels as a part of the diagnostic criteria.
And that's, so your question is very, very valid, but in some ways actually took me a little by surprise, because actually a lot of patients with MPNs actually have a high B12 level that we find at diagnosis. As to why some people have low B12 levels and others don't, it's difficult, and sometimes it's down to the assay. If we take outside of the MPN community, B12 levels notoriously can be variable, and taking one person's B12 level on one day and looking at it maybe a couple of weeks later, sometimes it can go from having a slightly low B12 level to being back into the normal range. There is a lot of reasons to take B12. Some people feel better in themselves for taking B12 supplements. However, from my perspective, I wouldn't recommend that people with MPNs have to take B12, so it's not a vitamin that you have to take. As to the most common cause of B12 deficiency would be a condition called pernicious anemia. And from my understanding, I don't know a correlation between having pernicious anemia, which is an antibody-driven autoimmune condition, and MPN. But does anyone else on the panel have any correlation between pernicious anemia?
No. I think just because you have an MPN doesn't mean you can't get something else, to be honest.
Very much so, yeah.
If I could just add to that, I think one of the really interesting things is that any patient that's on hydroxycarbamide will have large blood cells, and patients with B12 deficiency will have large blood cells. So often a GP may not realise that hydroxycarbamide causes the large blood cells. So you may find that you're tested for B12 folate deficiency because they can see there's large blood cells, but actually it's because of the hydroxycarbamide that the blood cells are large. So I think there is a correlation. Certainly I get a lot of calls, emails, contact from GPs saying this patient that you look after's blood cells are really, really large. Should I worry? And I just send back and say, no, don't worry.
It's a sneaky way sometimes of knowing if our patients are taking hydroxycarbamide, so be careful of that. Right, I'm going to ask, yes, go ahead.
I'm not quite sure how to phrase my question. It's more of a puzzlement. I got my diagnosis in August last year. The blood test wasn't conclusive, but the bone marrow was. The blood test indicated that I have PV, but I have molecular negative PV. I'm not quite sure what that means for my condition and how I manage it, other than with the aspirin. Is there anything else I need to be doing?
Alex, maybe you could answer that one. Trying to keep it as general as possible, because molecular negative PV, difficult, but go ahead.
I think the discovery of few mutations in the last decade helped us a lot, because that can confirm the diagnosis, because we know what's driving the disease. And in PV, up to more than 95% of the cases, we can identify a mutation. Now, there is always clinically very challenging what to do with the rest that we don't find the driver. Now, all of us have been trained in microscopy and looking at the bone marrow, and there are features in the bone marrow that can indicate that there is morphological, like the cells look like a PV diagnosis. So there are occasions when we can say, although we don't find the driver, we're pretty certain that the bone marrow is a textbook PV, but then the challenge becomes, what if it's intermediate? What if we're not completely sure? And then I think there is a lot of research, and many people in the panel here have done a lot of research about identifying other drivers and ruling out other conditions that may drive a high red cell count. So I guess in your case, if everything else has been ruled out, then it could be process in the bone marrow that's driving the disease, but not one of the described mutations.
Okay.
I'm on watch and wait in aspirin, and my hematocrit levels are good, so I'm not concerned by it, but I'm just puzzled, that's all.
It's a good
Thank
question, though. It's a good question. I'm going to ask Claire Woodley a specific question now about, so on her piece of paper she's got something about long-term effects of interferon, but specifically related to psychological side effects of interferon. So I'm going to modify the question to, what do you do if we're talking to you about giving a patient interferon, but they've got a history of low mood or a mood disorder?
Thank you. So really, when those patients are presenting in clinic, we want to explore their experiences with their mental health previously and how their mood has been affected in the past. Sometimes we will actually, before starting a patient on the medication who we think might have some concerns about tolerating it in terms of their psychological effect, we will refer into our psychology service or our psychiatry service so that we can have a baseline and they can have a discussion around those thoughts and feelings before we actually then start them on a treatment. Sometimes it might be dose dependent or frequency dependent. So for some of our patients who longer down the line might experience some issues, we may change their dose. We may reduce their dose on these patients or reduce their frequency. It's very difficult to predict when somebody's mood may or may not be affected by interferon. You know, it may be many years down the line and it might be as subtle as being a bit more snappy. You know, family members, it isn't at times, but yeah, and sometimes it's those subtle changes that might trigger us to kind of reevaluate perhaps the dose or the frequency. The main thing I would say for particularly our patients is to be able to have that open discussion with your clinicians. Quite often we're asking in consults about how is your mood on this treatment, but it's about being able to even mention those slightest changes and have those discussions with your clinicians. It doesn't always mean that we're going to take a drug away from you, but it's what we can do to make it the appropriate drug for you.
Excellent. And the app, you can use the app to monitor that. I'm going to ask Anna Godfrey, because she's got a microphone in her hand, to maybe answer the question she's got on the piece of paper. I don't know what the question is. These are questions that have come in online. So, Anna?
So the question I've got is about ET, and it is, do we have any further understanding of triple negative ET? Can you be negative at diagnosis and positive years later?
So quite similar to triple negative PV in a way. Yep.
Yeah, exactly. So I think triple negative ET is quite complex. There's a very long answer to this question. I'll try and keep it short. I think one of the things to remember when we think about making a diagnosis is that in medicine we've had blood counts for a long time, and then we invented the microscope, and then a lot later we learned how to do genetics. So the diagnosis of ET is a diagnosis that we used to make 20 years ago by seeing a high platelet count and then looking at the bone marrow biopsy down the microscope, and if the two things we felt added up to ET, that's how you got a diagnosis. Now we understand much more about genetics. So in that condition that we used to call ET, around just over half of patients will have a JAK2 mutation, around a third will have a CALR mutation, 5 to 10% will have a MPL mutation. And once we identified those mutations, we were left with about 10 to 15% of people who didn't have one of these clear driver mutations. And since then, perhaps we thought we'd find another driver mutation, but it hasn't come to light. So for this group of people, the question is what's really causing that underlying condition? And I think the understanding now is it's probably actually different between different people. There are some factors that we understand may be relevant. So Jyoti's done some really beautiful work looking at the genetics that we're born with. So the many, many, many genes that will contribute in some ways to our blood count. Perhaps in some people they're adding up together to mean that your platelet count is just pushed that little bit higher. It doesn't seem to be that there's some clear other cancer gene that we haven't found yet. So it's probably a very mixed condition, and for that reason, I think we have to be really clear about what that means down the line. So one thing we know about triple negative ET is that the risks of blood clots are lower, the risks of disease transformation are lower, and then when we think about treating it, we have to take that all into account and really take the individual and what their risk of complications might be. So we're hoping by next year to write a national guideline around some consensus recommendations how to do this investigation and management for this particular group of patients, because it is really tricky. But it's one of our areas where unfortunately we have probably the least good evidence. Just some thoughts from colleagues, really.
Yep, and Anna's done some fantastic work pulling that together. It's a topic we often ask her to talk to. So question in the room, lots of questions in the room. So coming to the back first, yeah.
So given the rarity of these diseases, and particularly when we look at the trials and studies that you're leading, you're often dealing with very small sample sizes. So how do you manage the uncertainty around those from the conclusions that you're trying to draw?
That's a really good question. John Lambert, do you want to answer that question?
Thank you. So I think it is a good question. I think it partly depends on the type of MPN that we're talking about, because some are more common than others. I think it really speaks to the fact we have to try to work collaboratively, because an individual clinician, particularly in some sort of smaller hospitals, may only see a relatively small number of these patients with MPNs. But I think if we collaborate nationally and internationally, as we have done over several decades, you do start to be able to develop trials which are big enough to be able to start to spot kind of patterns and then work out which treatments work. And we've seen this, with Magic PV, for instance, a really good example of how by collaborating you can get enough data. I think when you start to look at some of the rarer subtypes or the rarer kind of events, so for instance, when we're talking about people who've got PV who don't have a JAK2 mutation, or some of the rarer types of myeloproliferative disorders more generally, then that is more difficult, and what people tend to end up doing is start to do what you call real-world evidence, where you're not necessarily doing a trial where you're taking a group of people and then you're putting them into a trial where you're kind of asking them to consent and have a special treatment. You might go around asking a whole group of clinicians, do you have any patients like this in your clinic? And then we try to put it together and see if across the group we can see any similarities. So for instance, the work that we did for skin cancers are relatively rare amongst people with MPNs. We talked about the risks, but actually they're still quite rare. What we did by working across the whole of the UK, found almost 100 cases, and that allowed us to try to put together some sort of data. So I think the answer to this is collaborate. It's us working with colleagues around the world. And if the numbers still are too small, which occasionally, then you're having to sort of hypothesize, you're having to sort of work out, we can see this in this group of people, can we kind of translate it across? So I don't think there's a single answer, but I think the best that we can do is just to work together, both as clinicians and as a kind of a patient group as well.
Great answer, thank you. Mary?
I would like to ask a question from a selfish point of view. I'm in my fourth decade, so I've lived with ET JAK2 mutation for 42 years now, and I've been treated for that length of time as well. It seems that newly diagnosed young people these days are monitored rather than treated. And my question is, at what stage do we look at someone like me who's been on treatment for over 40 years and say, what's happening to my bone marrow and what is the long-term effects of taking all these hydroxycarbamide for 37 years, and now I think I'm in my fourth year of interferon.
Right. I'm afraid of answering that question as your doctor. But actually, the clinician on the panel who has the most experience is Mary Frances McMullen. So just a short answer, if possible, because we've only got a short amount of time and got lots of questions, so even more pressure.
So I have been sitting in one clinic for well over 30 years now, and I have many patients who I have been seeing all that time. There's really we monitor the patients. Don't forget, you're having your blood counts looked at all the time, and that is an indication of what your bone marrow is doing. You wouldn't really do a bone marrow again unless there was some reason from the blood counts to suspect there may be a change. So the doctor is very aware that you've been on treatment, or one has been on treatment for multiple decades. But as I say, they are managing from a blood count point of view. There isn't really anything specific that we know of that you would do to look at the bone marrow because somebody has been on a particular treatment. As I say, the blood counts are a very good reflection of what the bone marrow is doing. So don't volunteer yet to have bone marrows done every couple of years.
But something like molecular monitoring might help, and this is something we probably would want to look at in the future. Another question in the room. Where am I going now? Who's got a microphone? At the back, yeah.
Are we still of the opinion that it's about 300,000 with MPNs?
In
the UK?
I can answer that. I think it's less than 300,000 people in the UK. I think we think something 3 per 100,000.
Yeah, and that's still the figure even after the decades of...
I think that's probably roughly maybe newly diagnosed. We still don't know, and that's why something like the app study will really help us. So we have really bad national data, I would say.
Those figures really came from Glenn. Remember, he did the meta-analysis of all the studies and came up with incidence figures for each of the diseases, and that's about what they add up to.
Yeah.
The prevalence figures, which is what you really want to know, even when we did that meta-analysis, there just isn't enough information there to get good prevalence
Incidence is new patients. Prevalence is how many in total. Okie doke. Another question. There's at least one down here and then several all the way up here. Yep. Okay, let's go here first and then we'll come there.
Okay. My question is to do with the relevance of focusing on platelet counts. Patients with CALR type 2 have the highest platelet counts but seem to have the lowest instance of blood clots. In fact, it's been suggested in some papers that the risk of bleeding is greater than blood clots. So for such patients, is aspirin sort of a suitable treatment?
Natalia.
Are investigating that at the moment, and it's tricky because the reason to give aspirin is to prevent a clot, but in some cases we see an increase on the risk of bleeding. So there is some study suggesting to possible stop in patients with CALR and really high platelet counts. So I think we still need to go to individual cases. I would like to say, I mean, being close to Jyoti today,
described the CALR mutation.
So she described the CALR mutation, so probably we should giving that credit. But it's quite new in the scheme of time in medicine. So we still need to learn more about how is the impact of CALR in platelets. But there is some studies. I will be careful to stop, and it will be individual basis. Okay.
I think we're a bit at equipoise, and we are writing some new guidelines for ET, so hopefully be good. Jill.
Hello to everybody. Today we spoke a little bit in a couple of the presentations about Q-risk scores, Q-risk 3 and 4, in the context of cardiovascular events. And for the first time after 20 years of being an ET, MF patient, it was mentioned in clinic recently. So other than the sticky blood that we talked about and the excessive blood cells that we all have, is there a known relationship between increasing bone marrow fibrosis and the risk of developing arterial plaque with all the cardiovascular consequences? And the second part, and what role does inflammation play in all of this?
Okay, Jen, I did indicate that was coming to you. Are you happy to... So first is vascular risk, and second is inflammation. We did ask about inflammation and thrombosis this morning, so that could probably be...
Oh, really fair, okay. Microphone, is it working?
It's working.
You can hear me fine? Oh yeah, it's working fine. Good question. And I was guilty of mentioning Q-risk 4, which I did find provocative, and I was
quite a recent paper. I'm not sure what were you asking about fibrosis relationship, but I guess
fibrosis.
Sort of beyond that, actually, we know really clearly that people with MPNs have an increased risk of cardiovascular events, and that really is driven by the upregulation of JAK-STAT signaling. It is pro-inflammatory. There's increased platelet counts. Platelets are more active, and already in people as they get older, there is more plaque development. So you add all of that together, it sort of does quite nicely explain why there is an increased risk. I don't think there's a particular relationship with, say, increased fibrosis or otherwise, but there's, irrespectively across MPNs, there is an increased risk. And I think mentioning Q risk scores, etc., what I will say, and maybe the rest of my colleagues are better at this on the panel, I don't know, but I think historically we have insufficiently managed the risks, okay? We should be, there is various opinions whether it should be devolved out into the community with GPs or embedded within MPN services. We should be, on an annual basis, monitoring the Q risk scores and actually trying to proactively modify risks beyond cytoreduction in patients, and I think we should be doing that. So managing, and also people with MPNs take ownership and sort of make sure they are on top of it themselves. So looking at your cholesterol levels, your blood pressure, diabetes screen, and all the primary prevention methodologies that I think anyone who's maybe seen me in a clinic or talks to me, I harp on about it. So exercise, all the other methods you can use, diet, relating cigarettes, alcohol, thinking of all of the other non-medical things and modifying the risks that are really there and really enhanced in all MPNs is really important. You mentioned inflammation, and I think that's part of the disease biology itself. It certainly explains some of the symptoms that people experience. There's a lot of increase in cytokines, all those little inflammatory chemicals directly caused by the disease, and I think that does play a significant role in cardiovascular risk.
But definitely no correlation between fibre in the marrow and risk of vascular. So I'm going to ask Andrew McGregor. You've got a question in your hand as well, haven't you? Do you want to answer that while we get the microphone to the next person in the room that wants to ask a question? So Andrew.
Yeah. So this is a question from online. Is a raised white count an indicator of disease progression with ET? Are there other relevant indicators of progression? So I think it's important to say that we look at trends in blood counts, not one-off numbers. So we generally don't look at a one-off number and make significant changes based on that. And also, normal people can get a raised white count because they've got an infection, or maybe they smoke, or lots of other reasons. So, but I think if the white count in PV or ET is going up and up and up and up, that is potentially a sign that the disease might be changing. But we also look at the hemoglobin. Are people becoming more anemic? Is the platelet count changing? Is it going lower than what it was before, or is it going higher than what it was before? And also, that will often prompt us to look at the blood film, so that's looking at the blood under the microscope to see if we can see any changes in the shapes of the cells and any additional cells under the microscope. So we use a lot of things, and also symptoms, for the symptoms that you have been living with, if they change, if your spleen suddenly becomes bigger, then all of those things we take into account when working out to see whether the disease might be changing.
Great, thank you very much. Question over here, and then we'll come down here. Yeah.
I don't know if, I'm probably talking about something I know nothing about, but it was something I saw that was quite interesting, and I wonder if it could benefit us at all. And that's the CAR T cell therapy that Cambridge are doing. Is that anything that would be
so the
hope
person
for
who's
us?
delivered and developed the CAR T is Alex. What was your question about it?
Well, really, as I said, I don't know much about it, but I just wondered if it's something that could be quite hopeful for us in the future.
So we are, I think, there are problems with developing immunotherapies for MPNs, right? So immunotherapies were initially developed in the early 2000s. They have been very successful for lymphomas and other cancers. Now the problem with immunotherapy is you need to have a good target. And in MPNs, at the moment, the best target is calreticulin. So any immunotherapy, including CAR T, would most likely, at least for the next short number of years, would only target calreticulin mutated MPNs, which is around a third of all cases. Now for CAR T, it's still preclinical development. So we have to get to a phase 1 clinical trial to establish safety and then to look into efficacy. And although I can tell you it looks promising, many drugs look promising at this stage. So scientifically, yes, it makes sense. It's very promising, but we just have to wait for the clinical trials.
Thank you.
Great. And thank you, Alex, for all the work you've done. Fantastic job. Right, where are we now? Over here, Megan.
Hello. My question is on transformation, sort of 3 different things about it. How common is it for your MPN to transform either into another MPN or leukemia? What are the sort of signs you should be looking out for? And as a young patient, are you more likely to transform because you've had it for longer than an older patient?
Okay, so we did discuss some things around white cell count, and Andrew did a really good answer to that. Sorry, not a quite a good answer, but so I think we got the answer to that. But something, Rachel, maybe coming to you about how common is it for a disease to change, if that's okay. Yep.
So it depends on the type of MPN you have, and in terms of the percentage risk of transformation, whether it's ET, which is the lowest, and then PV, and then MF. So there is obviously a risk of transformation, which is obviously what we discussed, but it is generally speaking sort of low on the lower side. In terms of the things to look out for, well, we monitor you all very, very closely, and we're looking at your blood counts all the time. And I know that a lot of you will have sleepless nights before you come to clinic for that reason. But actually, in terms of symptoms, so in the blood counts, we look out for anemia, so drop in your red cell count. We look out for change in your counts, and they can develop the symptoms. So if you're anemic, if you're starting to get more tired or more pale, then you will all probably recognise some of the signs of anemia. And your white cells can go obviously down, or they can go up. So you may just feel different in yourself, but a lot of that also can be psychological as well, because you can be very anxious about it, and that's again very understandable, which is why I say we probably at the very beginning, certainly I don't know what everybody else does, but I tend to monitor people very closely initially, not because I'm worried, because I know they're worried. So I think that, I think all of you will be monitored so closely that between you telling us if you've got any new symptoms and then us monitoring you in clinic, we should be able to pick up those signs pretty early on. Okay.
So I think this is something that often patients are worried about when they come to clinic. And I know that. So I'm going to ask Alessia, who hasn't had the joy of answering a question, to read out the question she's got, and then we're going to come to this lady at the front.
Thank you.
Alessia.
So the question here from online is really for Dr. Patrick Harrington, who couldn't be here for the Q&A. But I'm part of the advisory board for the MPN app, so hopefully I can help answer this question. And it's actually a question which I asked him as well during one of our meetings. So the question is, can the app pull data from your own smartwatch? So this would be, I can see why people would ask this question, because they already have a smartwatch. But the thing about the smartwatch, which is posted if you get selected for that arm of the app, is that the smartwatch is an FDA-approved medical device. So it's been tested, and there are rigorous steps put in place to make sure that all the data is very accurate. So it measures your oxygen saturations and the pulse rate, and that all has to be precise. So the technology which the app uses to pull that data has to be linked with the medical device rather than your own smartwatch. And we know there are many different smartwatches on the market, and those are not FDA approved. And so we wouldn't be able to, at the moment anyway, link that data. So I hope that answers the question and explains the importance of having that specific device.
So what I can say also, in addition to what Alessia said, which is correct, is we are speaking to Sanius in the next stage about being able to link your own Apple Watch or whatever you've got, but for the study it would be specifically the Withings watch. And this lady's been really patient at the front, so go ahead.
Hello. My question is about the COVID jab. So I had ET and I was stable for about 8 years. When the COVID came along and had all the vaccines, I suddenly developed PV and my blood counts were all over the place. I've stopped having the COVID jab, so do we know, is there a relevance of having the COVID jab and what it does to your bloods?
Nauman, you've been handing out questions. Do you think you could take that one? Because I've been keeping a list, or either you or me haven't answered a question yet. So
yeah. Well, I'm not going to answer it very well, but there's a lot. So, as a medical community and the people with MPN, we do worry about your exposure to COVID, and it's important that you're protected. So I understand people's anxiety around the vaccine, and we do hear stories in clinic of people saying, I felt dreadful and my blood count control changed. We don't know what these vaccines really do, but it's all about a risk-benefit. And we all, as a medical community, feel that any potential risk of a vaccine is outweighed by the benefit. So that's kind of laying down the basic ground rules where I understand people's anxieties about these vaccines because they are new, but I think as a community we believe it's important that we risk balance it. So we can't guarantee that all vaccines are safe and they've been fully tested, but on a risk benefit it's important that we try and encourage the use of the vaccine. Whether it changes the disease process, again, I would find that hard to explain biologically. I'm not aware of any mechanism by which a vaccine would in any way change a disease from ET to PV or ETPV to MF. So I'd like to say that's probably coincidental, but again, couldn't promise you that there's no data down the line that would show that there's some kind of immune regulatory effects of having a vaccine that might do that. But again, like I say, that's pure speculation. So I think it's coincidental, and I would encourage people to engage with the vaccine programme on a risk-benefit basis.
I also think it does happen that patients do change from having ET to PV, as, for example, the amount of JAK2 goes up or something else changes, particularly women as we get a little bit older. We often find our patients change from having ET to PV, and that's something that was seen in the young people as well. Oftentimes our young patients changing their diagnosis. Might have time for one more question. And we've got a microphone with Alice. Excellent, Alice.
Hi, thanks very much for this panel. This was a question for Jyoti, if I may. I just wondered if you had any thoughts on young MPN patients in the context of your work on the clonal trajectories of blood cancers. I was so interested in your work showing that, for example, that a 65-year-old MPN patient might have acquired their JAK2 mutation 50 years previously. And I wondered, why do young MPN patients seemingly buck the trend in this older community? Why do they present much earlier in life?
Okay, while Jyoti's thinking about that, and she needs less than a nanosecond to think about it, I just want to give a big call out to you, Alice, and ask everyone in the room to give you a big round of applause for all the work you've done with young people.
Hi there. So I think the first thing to say is we're still learning about the journey of each person's MPN. So far we've done maybe 10 to 20 patients. What we are finding in that very small number of patients is that the JAK2 mutation seems to be early in many patients, but the time at which people present is related to how fast the clone grows. It doesn't always mean that the JAK2 mutation is early. Sometimes it can be late. There could be some other event, some other mutation, and the JAK2 mutation occurs later. So not in all patients is it early. I think in young patients, I probably don't have the data to support this, but my sense is that it's generally early and it grows. What we don't understand is why it grows that little bit faster than the older individuals, and you don't need the growth rates to be that different for it to then vary by decades between when people present. So I don't want it to cause alarm that something's growing super quickly or super slowly. It's almost like very slowly and slow can then lead to differences in someone presenting in their 20s and 30s versus their 50s and 60s. We don't know why. We don't know whether that's just random chance or whether there are things about one's DNA, maybe inflammation, maybe some other trigger. One thing we're particularly interested in is studying some children with MPNs, and we're collaborating with the US to study some children. I think that might help us understand if there's a different route. But at the moment, it feels like there isn't a different route, there's just a different speed. What we do get a sense of is once you treat it, it all sort of ends up being the same thing. It all slows down, which is reassuring.
Okay, so I'm going to close this session. Massive thanks to all of my colleagues. Huge thanks also to Nauman.